So, hello and good morning, everybody. I would also like to welcome our guests in Germany and Vienna. And first of all, before I start my presentation, I would like to thank you and congratulate the colleagues from Sono4U for organizing this great congress. Really great work from you. I think this course is pretty unique in all the European unit and maybe all around the world. So next 45 minutes, I'm gonna spend on a topic that's called lung ultrasound in acute care medicine. And later on, I also will spend some slides on the diagnostic workup of DVT with two-point compression sonography. My timeline for the first presentation concerning the ultrasound exam is as follows. First of all, I'm gonna give you some basic knowledge on pulmonary ultrasound, and then I would like to discuss 4 different diseases. First of all, pneumothorax, then pulmonary edema, pneumonia, and last but not least, pleural effusion. If we go a little bit in the past, we can see that lung ultrasound is a pretty new tool that became more and more popular only in the last maybe 10-15 years. For example, in 2001, the big Harrison principle of internal medicine wrote that ultrasound imaging is not very useful for the evaluation of lung parenchyma. And this was a result of the fact that ultrasound waves are reflected by air, and as we all know, the lung contains air, so everybody thought that ultrasound is not a good tool for pulmonary diseases. But right now, we do have a lot of studies that evaluated the diagnostic accuracy of pulmonary ultrasound in critical conditions, and we even have a point-of-care guideline for the use of lung ultrasound in critically ill patients. Everybody who's interested in this topic, I just can recommend this guideline. It's pretty long, but very, very good paper. So let's start with the basics. If we would like to do an ultrasound exam of the lung, we start with a longitudinal plane on the thoracic wall. So we put the scanning probe, as in this picture, in a longitudinal plane, and then we cut through 2 ribs. Here is one rib, here is another rib. On the surface, we can see the fat tissue and the muscles between the ribs. And down the ribs, we have some rib shadows. Here, we do not see anything because the ultrasound beam is reflected by the ribs. And between the 2 ribs, we get a white hyperechogenic line that's called the pleural line. And this line is very important in ultrasound of the lung. And this line is produced by the 2 pleural layers, the parietal and the visceral layer of the pleura. And this is an echogenic line which reflects the surface of the lung. All we can see down there is just artifacts and no real lung tissue. So you have to know that this, what we see down here, is not really the lung, but only artifacts. And normally we do see horizontal artifacts, that's also called A-lines or reverberation artifacts. And we always see these artifacts if there is air under the pleural line. So in normal condition, but also in pneumothorax, for example, okay? If we have a look on this image in a breathing patient, we can see the first very important motion sign of lung ultrasound. It's called the sliding sign or lung sliding. This is a normal finding, and what is meant by lung sliding is the breath-dependent motion of the visceral pleura against the parietal pleura. You can see it here, little white points moving right and left with every breathing motion. Can everybody see this? I think it's visible very good. Down there, what's this? Nothing. It's just artifacts, but no lung tissue, okay? This is just a mirror of what we see up there, and these are reverberation artifacts. So we can do another image of this lung sliding when using an M mode, we put the M mode just between two ribs, and then we get a sign that's called the seashore sign because it looks like a beach in the ocean. Okay, here in the area of the subcutaneous tissue and the muscles, we get a linear sign, and down there, here is the pleural line, and all down there, we get a sign that's more like sand in the appearance. This is because of the motion of visceral pleura against the parietal pleura, and this is the classical finding in a normal patient. It's called the seashore sign. It's the same as the lung sliding in a moving picture, but you can also record this for documentation, for example. The next sign that's important, if we talk about lung ultrasound, are the so-called B-lines. B-lines are vertical artifacts, like this here. They look like laser artifacts, like disco lights or stuff like this. They show breath-dependent motion with every pleural sliding, and they arise from the visceral pleura. And these B-lines are a sign of extravascular lung water. So when do we see B-lines? What do you think? In which conditions, critical conditions? Any ideas? Pulmonary edema, for example, but also in inflammation. Every situation that causes a higher amount of water in the lung tissue makes B-lines, okay? If we have a look on this image, we see it moving left and right. These laser-like artifacts are rising from the visceral pleural line and going down to the end of our screen. If the B-lines are arising from the visceral pleura, what do we know if we see B-lines? Any ideas? We do know that both pleural layers are attached to each other, so we can exclude the pneumothorax if we can see B-lines. That's very important for you. But I'll come on this back later, okay? The next sign is pleural effusion. That's pretty simple and a very old topic. Ultrasound is used for the detection of pleural effusion since many, many decades, and it's pretty easy. It's like in the FAST exam, we see echo-poor or echo-free area over the diaphragm, and often we see some consolidation within this effusion. This is caused by either inflammation, but more often by compression because of the pleural effusion. It's just the lung isn't filled with air anymore, and we see this consolidation. The next sign is subpleural consolidation. What is meant by subpleural consolidation? This is a situation in which the lung is not filled with air anymore, or some areas of the lung are not filled with air anymore, and they do consolidate, and we get an echogenic appearance of the lung tissue. In this example, this is a big pneumonia of a patient. Here, the lung looks more or less like the liver. We say hepatization of the lung, and this is a very small subpleural consolidation in case of pulmonary embolism, for example. Okay, so we see here the pleural line. The pleural line would be here, and down there we can visualize the lung parenchyma because it's not filled with air anymore. Okay, this is, for example, case in pneumonia or in pulmonary embolism or in melanoma. There are many different conditions in which subpleural consolidations can be seen, even in ARDS, for example. Okay. So far to the basics. Are there any questions on the artifacts, on the phenomena we found in lung ultrasound, or everything easy? Okay, no questions. So we continue. First of all, I want to give you some details about the detection of pneumothorax by ultrasound. Meanwhile, there have been conducted a lot of studies, maybe hundreds, that evaluated the diagnostic accuracy of ultrasound and radiography, chest X-ray, and we saw that ultrasound is way better than X-ray in a supine position. I know everybody does X-ray for the detection and rule out of pneumothorax, but if we look into the literature, ultrasound is definitely better. We have a very, very high sensitivity of about 90%, and we have also high specificity of almost 100% with ultrasound. In chest X-ray, we have a good specificity, which is clear, but we do not have a good sensitivity in this case, only 50% about. Okay. If we talk about detection of pneumothorax, which probe would you prefer? You see it on the screen. Of course, we take a linear probe because we want to scan superficial tissue, only maybe 4 to 5 centimeters of depth we need. So we do not need a convex probe or a cardiac probe. We take, if possible, a linear probe because we get the best resolution of our ultrasound image. If we have a patient with the suspicion of pneumothorax, it's very, very important that the patient is in a supine position. Because in this case, we can be sure that the air, also small amounts of air, are getting up on the surface of the thorax so that we also can detect very small pneumothoraxes. If we scan the third or fourth intercostal space in the mid-clavicular line is probably the most sensitive position to scan, but of course, if we have time and the patient is not in a too critical condition, we should scan several regions to get a higher sensitivity and specificity. Okay? So we put our probe on the anterior chest wall in the mid-clavicular line on a supine patient. Then we have to observe the typical sonographic findings of pneumothorax. The first finding is abolished lung sliding. In a patient with pneumothorax, in the region we scan, we cannot find lung sliding. Lung sliding always excludes the presence of pneumothorax in this area that I scan, okay? So if I see lung sliding, pneumothorax is ruled out in this position. And if we scan the third or fourth intercostal space, normally we can be pretty sure that the patient has no big pneumothorax that's the cause of hemodynamic instability or any other major breathing problems. Next, we do not see B-lines because we know that the B-lines arise from the pleural line, especially from the visceral pleural line, and this is the cause why we cannot see B-lines, because if there is lung between the two pleural layers, we cannot see B-lines. Okay, so in pneumothorax, we do not see B-lines. If we see B-lines, pneumothorax in this area is excluded. And in some cases, we can detect a point or a sonographic finding that's more or less 100% specific for the diagnosis of pneumothorax. That's the so-called lung point. What is meant by the lung point, I will tell you later, okay? Here, just a repetition of a healthy patient. We see pleural sliding, lung sliding here in the pleural line. We see the reverberation artifacts, but definitely the points are moving left and right. And on M mode, we see the typical seashore sign. Okay? If we have a patient with pneumothorax, on the left side, this is a moving picture. So patient is breathing. We see the ribs here. We see the muscles. And here would be the pleural line. But in this line, we do not see any movement. We only see a movement of the whole picture because the patient is in shortness of breath. But the pleural line itself doesn't move anywhere. Okay? So this would be an example of pneumothorax. And if we use the M mode in this patient, we find a totally linear sign all over the ultrasound picture, and this is the typical finding in a patient with pneumothorax. So the seashore sign is missing because there is no movement. We do not see the sand pattern down there. We only see the linear pattern C pattern. Okay, it's also called the barcode sign, but the names are not so important. Okay, this is finding of pneumothorax. In this patient, here we have got a patient with pneumothorax, and this patient has got no pneumothorax on the right side. Who can explain why this patient has no pneumothorax? What do we see on the right image? We see B lines, yeah, correct. So B lines exclude pneumothorax, everything okay. But do we see lung sliding in this patient? No, we do not see a sliding sign. We only see sliding of the whole picture because the patient is again in shortness of breath, but we do not see lung sliding. Any ideas what could be the problem in this patient? Pleurodesis could be, yeah, exactly, but this patient had pulmonary fibrosis, end-stage pulmonary fibrosis, and in these cases we sometimes cannot observe the sliding sign because the lung is very stiff and cannot slide anymore. But in this case we almost always see B lines because the lung is not healthy, and so in this patient we could exclude a pneumothorax on this way. It's the same in patients with ARDS or pneumonia. Sometimes we do not see the sliding sign because of inflammation there, but we always see, or nearly always see, B lines in these patients. Okay? So, now coming to the lung point. The lung point is exactly the point where the pneumothorax starts and ends. In this patient, this is a CT scan, then the lung point would be exactly here. Okay? So if we do an ultrasound scan over there, if we put the probe here, we see abolished lung sliding and the barcode sign on M mode. If we position our probe exactly on the beginning of the pneumothorax, we see the following sign. On the left side, we see abolished lung sliding. On the right side, we see normal lung sliding. So this is just the beginning and ending of the pneumothorax. You understand? I think yes. So if we find this sign, the diagnosis of pneumothorax is almost made because there is no other condition in which we can see a lung point. But what do you think? Do we always have to find the lung point? Sometimes we can't, but what's the reason for that? Yeah, if there is too much air and the whole lung collapses and is surrounded by air everywhere, we do not find the lung point because we need an area in which the lung is attached to the thoracic wall. Otherwise, we do not find the lung point. So in very, very critical ill patients, we do not find the lung point normally because if they have a tension pneumothorax, the lung is totally collapsed and we do not find the lung point. But in stable patients, we almost always find it. And normally, you find it on the lateral thoracic wall, somewhere in this area. Okay? If you find it, the diagnosis is made. So, what do the consensus guidelines tell us about ultrasound in case of pneumothorax? They say that lung ultrasound is more accurate in the rule out and rule in of a pneumothorax than supine anterior chest X-ray. So if we have a traumatized patient that's in a supine position, or we have a patient on the intensive care unit that's intubated and cannot stand up, for example, ultrasound is the method of choice, not chest X-ray. The advantage of ultrasound is also that I can do it immediately after the arrival of the patient, and I can repeat it as often as I want. Okay? What are the limitations? Of course, we have some limitations of this method, like every method. First of all, in my eyes, the biggest limitation is that we cannot accurately assess the size of a pneumothorax, because we cannot say if the area of air is 1 centimeter, 1 millimeter, or 10 centimeters, because if there is air, we do not see the visceral pleura, and so we cannot say how much air is in the thoracic region. And after this, we also have the cases in which pleural adhesions cause lack of lung sliding. For example, patients with malignoma, pulmonary fibrosis, or sometimes even pneumonia, severe pneumonia, or ARDS. But in these patients, normally we do find B-lines, and we can exclude a pneumothorax on this way. Okay? So, just for some clinical questions, what do you think is a good way to react if you find a pneumothorax? Should you always do an immediate intervention like chest tube insertion, or when would you do which procedure? Yeah, absolutely. So if you find a pneumothorax and the patient is stable, I would always do a second diagnostic test. For example, CT scan, or if possible, if the patient is in good condition and can stand up, we can do a chest X-ray into positions. Okay? If the patient is unstable and is in shock, for example, and we see pneumothorax on ultrasound, probably it's a good way to make an intervention like chest tube insertion without prior CT scan or any other diagnostic workup. That's what I think is a good way to react on it. Okay? Any questions on pneumothorax diagnosis? Yes? So for our colleagues in Germany, just a repetition of the question. The question was, how do we find the lung point? The lung point can be only found on sliding down on the thoracic wall, every intercostal space, and sometimes you find it in any you can find it everywhere. In very small pneumothoraxes, you can find it on the anterior chest wall. If it's bigger, you find it lateral, and if it's very big, you do not find it. So you have to scan the whole thoracic wall, and of course, we only can do this if the patient is stable. If the patient is in shock, we just scan two regions in the anterior thoracic wall and then make our diagnosis. Yeah. Any further questions? Oh. Okay. Then let's get to pulmonary edema. Colleague Schindler already told you that it's often very, very difficult to differentiate between pulmonary edema and exacerbation of COPD, because these patients often present very similar, because they show wheezing on auscultation. They often have comorbidity of cardiac problems and pulmonary problems. And even for very, very experienced physicians, it's often not too easy to make the right diagnosis. So this is why I think ultrasound is a really, really good tool to make the right diagnosis in patients with acute shortness of breath. There are a lot of studies on this topic, maybe hundreds meanwhile, but this is one of the first studies by Daniel Lichtenstein from Paris, who looked at patients with pulmonary edema and COPD, and he found out that in critically ill patients, all patients with pulmonary edema had the typical sign of pulmonary edema on ultrasound, the multiple B-lines on the anterior chest wall, and patients with COPD or healthy patients did not show these B-lines. Only very, very few patients in this study. So what do we find in these patients? We find multiple B-lines on the anterior chest wall. It's beginning on the basis and getting up to the apex of the thoracic wall. Often, we also find a pleural effusion, of course, if the patient is in chronic heart failure and is getting decompensated slowly, we often find also pleural effusion. And what's interesting that we find a direct correlation between the number of B-lines and the amount of extravascular lung water. So the more B-lines we can see, the more pulmonary edema we do have. That's a general thing. And the B-lines disappear very quickly after appropriate treatment. So if we have a patient in hypertensive pulmonary edema, for example, and we do treat this patient appropriate with non-invasive ventilation, antihypertensive medication, and maybe morphine, 20 minutes later, the amount of B-lines is often significantly decreased. So which probe should we use? Because of all studies have been conducted with cardiac or abdominal probes, we should use one of these probes, not the linear probe. Of course, you can also use the linear probe, but most of the studies have been done with other probes, and so the number of B-lines is better proven by this probe. So I would recommend to use a cardiac probe, or if not available, a normal abdominal probe. What do we find in patients with pulmonary edema? First of all, we have to divide the anterior and lateral chest wall in 4 quadrants, 1, 2, 3, 4. And then we scan every of these regions by using a longitudinal scan, as I showed you before. And then we count the number of B-lines. If we find 3 or more B-lines in one intercostal space, this area is positive. And if we have got 2 or more positive areas per hemithorax, we can be pretty sure that this patient is in interstitial syndrome, generally in pulmonary edema. Okay, so we scan 8 regions on the whole thoracic wall, and if we find 2 or more positive areas on each side, it's very probable that the patient is in pulmonary edema. Okay, it's not so important that it's a strict point where you have to scan just one scanning area on the apex, 1 on the basis, and 2 on the lateral thoracic wall, and it's fine. So you don't have to count the intercostal spaces or anything like this, just scan 4 regions. Normally, 2 regions anteriorly are enough, because if it's positive, all the others would be positive too. So this would be a patient in pulmonary edema with a cardiac probe. Here we can see 5, 4, I don't know, but many of the B-lines, laser-like artifacts that go down the whole ultrasound image. And here we have got 3 B-lines in a patient with pulmonary edema. This is an abdominal probe. We find the same. We see here the pleural line with laser-like artifacts going down the whole picture. Okay? And of course, in one intercostal space here we can see maybe 5, 6, 7 of the B-lines. Okay? For example, this would be a patient with acute shortness of breath. The ultrasound exam showed only here 1 B-line, maybe here 1 B-line, and here we only have the reverberation artifacts. So in this patient, we can rule out pulmonary edema, and this patient was in acute exacerbated COPD. This patient was in pulmonary edema. Why is that? What do we see? Yeah. Everywhere more 1, 2, 3, 4. It's not a moving picture, so it's sometimes pretty difficult to count the number of B-lines, but we can see that there are a lot of B-lines, so this patient would be in pulmonary edema. And it's very, very easy. So we know that students that only get a course of 2 hours and have no ultrasound experience can exclude or diagnose pulmonary edema, because you do not have to find any structures. You only have to see the lung surface and the B lines. And if you've seen it once, you will always find it again. Yeah. This doesn't really, so the question was just repetition, if the patient has to be in a supine position or also possible in sitting position. In this case, it doesn't matter. Patient can be standing, sitting, lying, however, doesn't matter. It's always looking the same. The basis, yeah, of course. It's normally it's starting down there on the basal areas, and if the patient is in severe pulmonary edema, severe shortness of breath, hypoxemia, the B lines are going up to the apex of the whole lung. I would always recommend not only scanning the basis, because sometimes if we have a patient in chronic heart failure, they sometimes always show B lines on the basis because they're always slightly decompensated. You know, if the ejection fraction is maybe 15%, these patients are never totally dry. So in these patients, if you want to know if shortness of breath, acute shortness of breath is caused by pulmonary edema, I would always scan the anterior and apical regions too to know if it's really severe pulmonary edema, okay? And it's a matter of 2 minutes maximally, so it's no big deal. Okay, also here, the consensus statements tells us that ultrasound is way better than conventional chest X-ray to include and exclude pulmonary edema. So we know that we are better using ultrasound than chest X-ray, auscultation, or any other clinical findings. What are the limitations? Of course, there are limitations. We can find some focal B-line patterns in patients with inflammation of the lung, for example, in pneumonia or pleuritis, but we do not find multiple diffuse disseminated B lines on the entire chest wall. In these patients, for example, we can find one area on the left side apically with a lot of B lines, but the basis is free of B lines. In this case, we can exclude pulmonary edema because pulmonary edema always starts from the basis and goes up to the apex, for example. And if only one region is positive, this is not pulmonary edema. In patients with acute respiratory distress syndrome, we also sometimes find a lot of B lines on the entire chest wall, but normally in these patients, and these patients are normally not getting into the emergency department, they are normally on an intensive care unit for a long time, so you normally know already what's the problem of the patient. But if you get such a patient, you normally find normal areas next to areas with a lot of B lines. This is something you would never find in pulmonary edema. So in these patients, it's very hard to differentiate, of course, because ARDS is kind of pulmonary edema, as we know, but we can differentiate it if we are experienced, but that's not the easiest thing, I would say. And in patients with pulmonary fibrosis, we often see multiple B lines, but pulmonary fibrosis is a pretty rare disease, so you won't see too many of these patients. But in these cases, it can be difficult to make a differentiation. Questions on pulmonary edema? No. So let's get to the pleural effusion. Just some slides. Here is a comparison of different methods. Auscultation needs about 400 milliliters that we can diagnose pleural effusion. Chest X-ray in supine position needs about 500 milliliters. That's pretty a lot. Chest X-ray in 2 planes needs 200 milliliters to get diagnosed. CT scan of the thoracic region, it's very, very sensitive, 10 milliliters, but ultrasound is also probably the same as a CT scan. We can diagnose pleural effusions if they are very, very small. So probably ultrasound is the gold standard for the detection of pleural effusion, I would say. But maybe also CT scan of the thorax, but not chest X-ray. What do we see? Normally, we see echo-poor or echo-free areas between the two pleural layers, as I showed you before. And frequently, we can see consolidations within the pleural effusion just because of the compression that is caused by the water between the two pleural layers. Which probe should we use? Either abdominal probe or cardiac probe, I would recommend. This is a patient with pleural effusion. You did already see it probably during the fast scan lecture. It's more or less the same, but here it's not blood. Here it's just fluid. We can see here the spleen, the diaphragm, and here this black area is the pleural effusion. Here again, another picture with the cardiac probe, the liver, diaphragm. Here, this black area is the pleural effusion. And here we can see some little atelectasis due to compression. Okay? That's all about pleural effusion. I think it's not too important to count the amount of pleural effusion because that's normally very difficult. And ultrasound is not the best way to really estimate the amount of effusion, but it doesn't matter because an intervention always needs symptoms of the patient. So if the patient is symptomatic, we sometimes have to intervene smaller effusions, and other patients are adapted very well to big effusions and do not need any invasive procedure. Okay, so the last part of pulmonary ultrasound is detection of pneumonia. Meanwhile, we do know that pneumonia can be detected by ultrasound very well. A lot of studies have been conducted on this topic. The biggest study was a multi-center study in which we also participated. And in this study, the ultrasound exam was compared to chest X-ray in patients with the suspicion of community-acquired pneumonia. And in cases with discrepant findings, CT scan was done in these patients. So, which probe should we use? The best probe for detecting pneumonia is the abdominal probe because we can see also the surface and a bit more of the depth. Sometimes consolidations can be pretty big, so the linear probe is sometimes uses too high frequencies. But of course, if you want to see very small consolidations, the linear probe is the best because we have the best image quality in the very, very superficial structures. Which findings do we find on ultrasound exam in patients with pneumonia? First of all, the typical finding is subpleural consolidation. Here we've got two different consolidations. On the left side, we see a very, very big consolidation in a patient with big pneumonia. On the right side, it's smaller consolidations. Also patient with pneumonia, but not so big consolidations to see. The consolidations normally are polygonal or oval. In this case, polygonally, here oval. This is a very small consolidation, but also consolidation. Here we've got the pleural line, and down there we can see an echo-poor region where the lung parenchyma can be seen. And here, for example, we do not see the lung parenchyma because the lung is filled with air, and we only see this small part. In this patient, we do see more of the lung parenchyma because we have a bigger consolidation. Normally, the margins of the consolidations are blurred, so we could not say where it really ends. Here down, the ultrasound image, maybe here is the end of the consolidation, but we cannot say where is the end of the consolidation. So that's the typical finding in pneumonia. For example, in patients with malignant disease, it's often very sharp. It shows sharp margins, and in patients with pulmonary embolism, we also see sharp margins. Normally, we see a breath-dependent motion of our consolidations. Like in this patient, every breathing, we see a movement of the consolidation, and also in this small consolidation that we did already see before, we can see a breath-dependent motion. A typical finding in pneumonia is the so-called air bronchogram. What is meant by air bronchogram? It's small air inclusions in the consolidated lung. It's white points or tree-like white structures that are within the lung that looks like the liver. Okay? Here we have some tree-like inclusions of air, and here it's more like points. Okay? You see that? And what we do also often find is a small pleural effusion in patients with pneumonia. This is not unlikely because of the inflammation. We often get small effusions in these patients. Okay, the consensus statement tells us that ultrasound is clinically useful in the detection of pneumonia, but we have to be aware that in some cases, especially in lesions that do not reach the pleural line, we cannot detect the consolidation and the pneumonia because the ultrasound beam is already reflected by the air on the surface, and we do not see the consolidation if it's not reaching the pleural line. In our study, the sensitivity was more or less the same as chest X-ray examination in 2 planes. So if we compare it with chest X-ray in 1 plane, we probably have a better diagnostic accuracy of lung ultrasound. But the problem is that it takes time. If we do not hear anything on clinical examination or the patient doesn't have pain on a very specific position on the thoracic wall, we have to scan the whole thorax that we can diagnose pneumonia if we do not know where we have to look first. And this needs time, maybe 10 to 15 minutes. And in an emergency department with a lot of patients waiting for you, it's sometimes difficult to use this tool. But in situations where we want to avoid chest X-ray, for example, in pregnancy or in children, of course, it's a great tool that can be used everywhere. Okay, so far, so good. Any questions on pulmonary ultrasound? Is it difficult or easy compared to other exams? What do you think? Easier, isn't it? We do not have to find a lot of structures, just the lung surface, some phenomena, and then we are done. Okay? So I'm sure that all of you will be able to do an exclusion of pneumothorax and pulmonary edema after this course, for sure. Okay, let's have a look on the time. So we are almost done, that's good. Now, just a few slides on 2-point compression ultrasound in patients with deep venous thrombosis. What we are talking about is a region here in the thigh around the inguinal ligament where we want to scan the femoral vein, the common femoral vein, and down there in the popliteal area, we want to scan the popliteal vein. Just 2 strictly defined regions, and all the rest of the venous system we do not care about in this ultrasound protocol. Of course, we have to be aware that we cannot find every thrombosis, especially if the thrombosis is localized in the lower leg. We won't be able to find or exclude this thrombosis, but if our exam is positive, we know that this patient has thrombosis, and at least this exam is easy and quick to do, so it's always good to have a look on it, but we cannot be sure that we do not miss smaller thrombosis on the lower leg. That's important that you know before. So how does it work? It's pretty easy. We just use the ultrasound probe and try to compress our vein. If the vein can be compressed totally, we do know that there cannot be any thrombosis. Like on the left, on the middle picture, we see a compressible vein. On the right picture, we can see the vein within a thrombus within the vein, and this vein would not be compressible. So we just use compression to see if the vein is compressible or not. If the vein is compressible, we can exclude thrombosis in this region. If it's not compressible, it's very likely to be thrombosis. How to differentiate between artery and vein, I think you all know. Yeah. Not? What can be used for the differentiation between vein and artery in ultrasound? Color Doppler, yeah, you see pulsation on color Doppler, on pulsed wave Doppler, of course, the signal is different, and of course compression. Veins are compressible, arteries can normally not be compressed totally, okay? Which probe do we use? Normally, in not too adipose patients, we use a linear probe, but sometimes we also have to use the abdominal probe if the veins are very deep down and we have to go inside like 10 to 15 centimeters. It's sometimes better to use an abdominal probe. First of all, we do start in a supine position to scan the femoral vein, like here, in this position, around some centimeters below the inguinal ligament. And then we scan the area of the popliteal vein, just within the area of the knee. For this region, it's sometimes better to use a prone position because it's easier to get a good view of the popliteal vein, or you can let the patient stand up and use a standing position as well. But lying supine position is the best for the femoral vein. So here an example of a normal femoral vein. Here we can see the artery, not compressible, pulsation, okay? Here is the vein, and it's compressible totally, okay? You can see the total collapse of the vein. So in this patient, we could exclude thrombosis, okay? Here we can see some color Doppler, and also here we can see that the vein is compressible totally. So what are the normal findings? As I already mentioned, complete compression of the vein. The lumen is echo-free, and if we compress the lower leg, we can see some flow acceleration on color Doppler more proximally. Okay? What are the ultrasound findings in thrombosis? We can see the thrombus. It's more not echo-free, it's echogenic, gray on the ultrasound picture. And we do not see any flow on color Doppler. Here, for example, a very big vein with a thrombus inside. Here the artery with flow. Here again, artery. Here the vein with the thrombus cannot be compressed, no flow inside the vein. Here again, artery, vein with thrombus. What do we see here? The bladder, urine bladder, yeah, because this is already in the pelvic region. Here again an example, two arteries of the femoral region after the bifurcation. Here the vein that's not compressible, that's bigger than normally, and we can see some echogenic material inside the vein. Once again, an example. Flow in the artery, no flow in the vein, and not compressible. This is case of thrombosis. Okay, that's it. I hope you understood everything. Are there any questions from the audience in Graz? No?
Well, I don't see any questions right now. Are there any questions on the video conference? There's someone looking really close to the screen. Where is it? Berlin. Berlin, have you got a question? We'll try to unmute you so you can speak. Give it a second. Yeah? Berlin, can you hear us? Okay. I guess they can't hear us.
Okay.
We'll make sure that if they get the questions to us, we'll get it to you and you'll give them an answer, I guess. Oh well, there's a question here. Oh no, that's our technical team asking if there's a question. So well, we'll leave it at that. Thank you for your time. Was great to have you, and we've got a little present. And
thank you
for you as well.
Thank you. Okay.
And now on to the organizational stuff. So there is some things that are relevant to everyone, both the and the other universities. So at 3 p.m.